Good afternoon and welcome to the October edition of the Benefits Lunch Break webinar series. Uh, for those of you that have joined us before, you know we have a few admin stuff to go through before we get in here, and I want to actually announce I have my colleague Brett Liefbroer here. Brett, say hi.
Hello, everyone.
He's going to be joining me on the podcast webinar, whatever we call this today. But we have two more scheduled dates for this year, November 15th and December 20th. And I have to talk to some colleagues, but I think December 20th, we're getting really close to Christmas on December 20th, will be the whole group, and it'll be ask the benefits lawyer like we've done the past few years. So mark those on your calendars and hopefully you can join us. Again, if you guys have certain webinars or certain topics you'd like to see us post on, please let us know. Oftentimes we have topics that we know that we've got to get to you, but sometimes it's a little dry in the benefits world, if you can believe that. And it's helpful to have suggestions. So please either post that in the Q&A feature, or you can do that on the survey that comes after the webinar. With that, let's get started. So today we are going to go through the end of the year health and welfare benefit plan items that you should be aware of and be on the top of your mind. And really, it really is a list of things that you need to think about. So we don't have a ton of material prepared, so we're hoping that we get some questions from you guys to make this better for everyone. And again, you can submit those questions through the Q&A feature. One of the reasons I have Brett, not only because he knows all this stuff, but it's hard to do present the webinar and monitor the Q&As at the same time, if you can imagine. So with that, we'll get started. So obviously as you know, there are notices that we need to get distributed every single year. And we'll start with those. The first one, Women's Health and Cancer Rights Act notice. A lot of people include these in the SPD, which is fine. We include them in all of our WRAP SPDs, but unless you're distributing the SPD every single year, which I think is rare, then we have to have this notice separately. So what we often see is that it's contained somewhere in the open enrollment materials. Second, the Medicare Part D notice of credible or non-creditable coverage. What's weird about this is we think about this as an annual open enrollment notice, Brett, because most plan years are on the calendar year, right?
That's right.
And so, but the requirement of this notice is that it's distributed annually, and it has to be distributed annually by October 15th. And why does October 15th why is that a special day? Well, if you've been watching any TV lately, you've probably, like me, seen a lot of Medicare open enrollment advertisements, and it's because Medicare open enrollment starts on October 15th. Now, this notice generally only has to be distributed to those participants in your plan that are Medicare eligible, and you may know that for your employees, but not necessarily for their spouses. So most of my clients will distribute that annually to everybody, even their 20-year-old employees who are obviously likely not eligible for Medicare. HIPAA notice of privacy practices. This is a notice that needs to be distributed upon initial enrollment in your health plan, and then the rule is it must be distributed at least every 3 years after that. Which, if you're thinking about how do we monitor that could be difficult, right, from an administrative standpoint. So what we recommend is since there is an alternative option, you can just notify participants every year, every 3 years of their ability to get the notice. So since you are going to have multiple, people are coming up on their 3-year distribution period at different years, again, in your open enrollment materials, you may just want to include a notice that says, hey, we're committed to your privacy. And we have this notice of privacy practices that tells you how we're committed to that. And if you'd like a copy, please call human resources, call personnel, call this person, email this person, or whatnot. The CHIPRA notice, the Children's Health Insurance Protection Rights Act. I don't even know exactly what that is, but anyway, that notice must be distributed annually. If you only have employees who are residents in Michigan, we don't actually have a CHIPRA program. We are one of the few states that don't. So CHIPRA notices are not required to be distributed to Michigan, participants in Michigan. But if you have participants outside of that, keep that in mind. And if it's easier, you're never going to get nicked or penalized, if you will, for distributing a notice that you didn't have to. One thing to keep in mind is these chipper notices are updated every 6 months on January 31 and July 31. So in the date, if you're looking at the chipper notice in your mind, you've got that chart of all the states. Right above that is a letter about, or is a paragraph that talks about when was the last, what effective date that chipper notice is. So take a look at that. Make sure that you're distributing the most recent chipper notice. Brett and I think a couple years ago, Brett, we did this where we compared one just 6 months to another with our Redline software, and we found like a lot of telephone numbers for states or email addresses had changed, correct?
Yes, there is a lot of detailed contact information in these chip notices. So it is important to always look at the latest notice and make sure you're distributing it to your participants.
Absolutely. And we found sometimes, like when I review notices, you got one from like January 31 of 2014. Keep in mind that those are updated. Summary of benefits and coverage of the SBC. You guys know that. I'm not going to spend a whole lot of time. If you have questions, please ask. Notice of grandfathered plan status. If you are on the call and you have a grandfathered plan, please raise your hand if you can. I don't think there's many of those exist, but in any materials that describe the plan, you have to have a grandfathered plan status notice, if applicable. If you have wellness programs, keep in mind that if it's subject to HIPAA, which it probably likely is, unless it's a participation only wellness program, you have to have a notice of reasonable alternative standard. And that's basically, how can I achieve the wellness benefit through another means if the normal standard is not medically able, I'm not medically able to do it. So, you know, for example, the easiest one is probably a tobacco cessation program, right? And what is the most common reasonable alternative standard for tobacco cessation? If I smoke or use cigars or chew or any of that, and I say I can't stop, what's the most reasonable, what's the most common reasonable alternative standard?
The most common reasonable alternative standard that we would see is a tobacco cessation course that you would require your employees to attend.
Yep. And that has to be paid for by the employee or the employer?
By the employer.
Correct. And it can't be overly burdensome. So it can't be some class that requires, you know, you to attend an hour class, you know, 5 days a week. And here's a question. I'm gonna quiz Brett on this and hopefully he gets the right answer, because this is one that bothers a lot of my clients. Let's and I'm gonna use myself as an example. Let's say I smoke. I don't smoke. I used to, but I don't anymore. Let's say I smoke and I can't attain that standard. And so I take the cessation class, but I complete it. I go through the whole thing, I complete it, but I still continue to smoke afterwards. Do I still get the wellness incentive?
Yes.
Yes, you do. Brett, you got it right. And that, of course, is something that irritates a lot of my clients. But once they complete that cessation class, if that's the reasonable alternative standard, they get the wellness credit or avoid the wellness penalty. Also, keep in mind if your wellness program has a disability-related inquiry or a medical exam, so health risk assessments, biometric exams, we also are then subject to GINA, and there's another special notice that has to go for that. SPDs only have to be distributed once every 5 years, 10 years if you don't make a material change to your plan. That's rare. So I would say once every SPD. And while you're thinking about it, if you're going to distribute the SPD, when was the last time you've had it updated? We've had a lot of changes in the Consolidated Appropriations Act, many of which took effect in 2022. In fact, I would say that it's probably the most significant piece of legislation impacting group health plans since the Affordable Care Act. So if you don't have anything in your SPD about the No Surprises Act, patient protections because of transparency, like provider directories, any of that, let's take a look at that, and maybe it's time to update that SPD. Lastly, I threw on there the summary of annual report. This isn't really an annual open enrollment notice requirement. But this is if you're filing 5,500 on behalf of your health plan, which you're required to if you have at least 100 participants in there, you have to do a summary annual report. And generally, I think the deadline for that is 9 months after the end of the plan year. But if you extend, this is a summary of the 5,500. So if you've extended your 5,500, the deadline then is I believe 2 months after the deadline of the extended 5,500. So keep in mind, especially since the deadline for the 5,500 extensions were, if you're a calendar year plan, was October 15 of this year. Which what is the date today? Is it
October 18th.
Okay, so see, we're already in there. Thanks, Brett.
Yeah.
And Brett did that off of memory. I'm looking at my watch and my phone. So good job, Brett. All right, so some changes related to the expiration of the COVID-19 pandemic. So remember, we had all of these extensions and special rules that applied during COVID. We're outside of the public health epidemic for COVID, thankfully. And hopefully that stays the same. So what does that mean? So, remember we had COBRA, HIPAA special enrollment requests, claim and appeal submissions that had to be extended for at least a year, correct, Brett?
Yes, that's right.
And those generally ended on July 10 of this year, meaning that, if you on July 9, if I had lost my job or terminated my job and got a COBRA right, once again, it's just I have now 60 days once I get my COBRA notice to elect COBRA. And so all of those that have been paused during the year have expired.
Right. And that July 10th date is based on the end of the presidentially declared national emergencies, which actually happened back in May of this year.
Yeah, but remember, it happened in May 11th or something.
Yes.
But remember, the outbreak period actually extended 60 days beyond the end of that outbreak period. You're also no longer required to cover COVID testing on a first dollar basis. So if some people are getting COVID tests, your plan can subject that to copays, deductible, all of the other participant cost sharing. Over the counter COVID-19 tests. So remember, for those of you that remember that, it was great, but it was really hard to administer. Like if I'm calling or going out and just getting COVID tests, I can submit those claims for reimbursement. You don't have to cover OTC COVID tests anymore. All of these are permissible, by the way. They're all still medical expenses. Your plan still can cover them, but you're not required. And then while you are still required to cover COVID-19 vaccines, you don't have to do it by out-of-network providers because COVID-19 vaccines fall in that preventive care mandate under the ACA. So I guess if you're a non-grandfathered health plan, or if you're a grandfathered health plan, you don't have to cover those. Again, I think those are relatively rare. And then we had this telemedicine issue, which has kind of been like a yo-yo, right, Brett?
Right.
Covering telemedicine, especially by high deductible health plans. The issue was if I cover that before the deductible, I'm no longer HSA eligible, right?
Right. And telemedicine, it's becoming increasingly more popular. So this is a provision where an extension could be likely.
Yeah. So
again,
we got that relief during COVID, and then they ratcheted it back, and then it expired. And then we actually, I think in March of 2022, they said, okay, we're going to put it back in, but there was a gap in the period. And right now, as long as you have plan years that begin before January 1, 2025, you can still cover telemedicine without any deductible, without jeopardizing HSA eligibility. I do expect this at some point to be, I know the government is pretty non-functional at this point. I was watching the C-SPAN again this morning, and we still don't have a Speaker of the House, for those of you that don't know. But I do expect that this one will probably be extended. I wish they would just extend it and, not extend it a further period and just say it's fine. But keep your eyes on that. And of course, if and when that happens, we'll be all over it, right, Brett?
Yes.
Reporting transparency. So gag clause. So these are basically provisions that say, hey, any of our service providers can't have a provision in the contract that prevents them from disclosing certain information to the plan sponsor, plan participants, other providers, people even eligible for the plan but are not necessarily enrolled. That's one thing. But now you need to attest to the government that your plan complies with this. And the way you do that is you submit it through the Center of Medicaid and Medicare Services, HIOS, or Health Information Oversight System. So if you go out there and you have a fully insured plan, you may want to check with your insurer, but they're also subject to this requirement. They're likely to going to complete this on your behalf. Self-funded plans, the obligation, it rests with you. Your TPA can do it for you if they agree in writing to do it for you. And so what we found out is that last week, Blue Cross Blue Shield of Michigan gave a webinar that I attended that said, hey, we're going to give you the option. You guys can self-submit on your own, or you can have Blue Cross Blue Shield of Michigan submit on your behalf. And then they require some limited information, your name, contact information, EIN number, and then a plan number if you do have an ERISA plan number. Priority Health, and I only touch on these two because we're a Michigan-based client, we're a Michigan-based firm, and these are the two big service providers for most of our clients. They're currently requiring their self-funded clients to complete this on their own. They're sending a letter that attests that says we comply with this, but you need to do it on your own. And the reason I have currently there in parentheses is now that the Blues have come out and said we're willing to do it on our own. I think the pressure campaign on Priority to say you do it on behalf of our self-funded clients is going to rise. So that could change. But keep in mind, and HIOS is not a user-friendly system. So if you are with Priority, you should probably start creating a user account, and we can help you with that to make sure that you're able to do this, because you will want to complete. But if you have the ability, the TPA, to do that, I recommend that you do it. And for nothing more than you're relying on their word that your plan complies with this law. If it doesn't, there's some liability that may lie with the plan. But I wouldn't want to attest. At least you can say, okay, our plan doesn't comply with this if they find out it doesn't, but we didn't attest that it did. These service providers who hold all the contracts, they attested to it.
And one additional point that I'll add here is the initial reporting period is actually December 27th, 2020 through the date of the attestation. So we're looking at a multi-year period here. So you may need to coordinate with multiple insurers or TPAs to make sure someone is filing these attestations.
Yeah, and that's a little bit confusing because I was recently at a conference with some Department of Labor and IRS attorneys, and as long as you attest, there's no in the attestation. If you look in the form, there's no way to limit the period that you're attesting for. You basically, if you attest, you're attesting for that whole 2.5 year period. But you may have TPAs that say, at least in writing, our attestation only applies to the time that you were a client of ours. So from an attestation standpoint from the government, you'll probably be okay if only one TPA attests for you. But if you have switched TPAs somewhere between December 27th, 2020, and that's a crazy date, Brett, but why is it that date?
That is the date that legislation that you mentioned earlier, the Consolidated Appropriations Act of 2021, was enacted.
Yes. So of course they couldn't make it easy. I remember being up north shortly after Christmas at my in-laws and reading through this and texting Brett like at 12:30 at night saying, have you seen this? This is going to be some significant changes for our clients. So anyway, if you have questions about that, feel free to reach out with us. Transparency and coverage. So for those of you probably know, you've gotten these links from your insurers or your TPAs that have all this huge data file, these machine readable files about pricing information. Well, one of the requirements is that you include certain pricing information for prescription drugs. Due to the fact that you have to do RxDC, Medicare or prescription drug reporting annually now every year under the Consolidated Appropriations Act, which we'll touch on here in a minute, the department said, hey, we're gonna put a pause on your requirement to include the prescription drug information because we want to see if there are overlaps. Well, they have recently issued guidance that said that pause, we ended it. And so the big question is when do we have to start including this in the machine readable files? Because the FAQs that they issued on this, not clear at all. I mean, didn't say anything. Again, I attended a conference the other week with some Department of Labor and Treasury attorneys. They have indicated that information does not need to be included until they issue technical guidance on what their expectations are. So you're good to go right now, but just keep that abreast, to make sure that you're monitoring that. And again, we will be I'm not sure if that will warrant another webinar, but we'll certainly do a client alert when that comes out. More transparency stuff. Have your service providers, remember now, like retirement plans, service providers, brokers, consultants, have to provide compensation disclosures as long as they think that they'll get compensation in excess of $1,000 in regards to providing those services to your plan. Have they provided those disclosures? If they haven't, time to ask. And if they won't do it, you should give us a call because you might have to report that to the Department of Labor. Because if they don't do that, it becomes a
prohibited transaction,
which can have fiduciary responsibilities or consequences under ERISA. Medical drug cost reporting, again, that's due every year. You've probably done that yourself or had your TPA or insurer do that. Just keep in mind that's going to continue to be due June 1 every year. The next one is June 1. CMS reporting to Medicare credible coverage. A lot of people get those credible coverage notices out, like we talked about earlier in the notices. But don't forget that you also have to report that to CMS. And again, if you're fully insured, your insurer is probably taking care of that. But if you're self-funded and your TPA isn't, you have to do that on your own. And it's due 60 days after the beginning of the plan year. So if you are a calendar year plan year, that deadline is March 1, 2024. HIPAA breaches. Hopefully nobody had any HIPAA breaches in 2023. But if you had a HIPAA breach that affected less than 500 individuals, in addition to notifying those individuals of that breach, you need to notify HHS and the Office of Civil Rights by 60 days after the end of the calendar year, which again is March 1, 2024. So if you had any breaches that were less than 500, keep that in mind. We have 60 days after the end of this year to report those. And then everybody's favorite 1094C, 1085C reporting. First of all, there's no more good faith effort. If you mess up, you're potentially going to be subject to penalties. You can obviously always try to do reasonable cause abatement requests, right, Brett? But
that's right.
You can't say I tried and I slipped. There's no more good faith relief on that. The deadline to get these forms to individuals is generally January 31 with the W-2. No more extensions on that, except for they put in kind of this permanent extension of 30 days, which makes it March 2. Also, if you are still doing these and reporting them to the IRS in paper, it's likely you can't do that anymore because now what's the threshold? Do you remember what the threshold level is of forms?
It is now 10.
10 forms.
It previously was 250.
And you have to, when you look at 10, you have to look at how many you have to combine that with forms W-2
right.
that you're reporting. And frankly, if you are an applicable large employer, you have at least 50 employees that need to be getting this, no less W-2s. So now, if you've been doing it in paper, keep in mind this year you are going to have to do it electronically. Section 125 plan updates. So the family glitch, Brett, do you want to talk about this at all, about what the family glitch was and what the fix is?
Sure. So the family glitch is basically this issue where affordability for purposes of an individual going out onto the exchange and getting a premium assistance subsidy has historically been based on the employee-only cost of coverage. So in many circumstances, family coverage for dependents or family members is the coverage that they would want to enroll in, and it may not be affordable for them. But it didn't matter for purposes of these subsidies because, as we mentioned, the subsidies were based on the employee-only level of coverage. So that has now been fixed. Affordability for purposes of the subsidies is now based on the cost of family coverage for family members. And your Section 125 cafeteria plan may or may not have this included in the plan.
Yeah, so previously your Section 125 plan probably had this provision that said, hey, if someone becomes eligible for the credit, they can drop coverage under your plan as long as they roll in subsidized coverage through the exchange that's effective no later than the next day. But let's say I had, so now they fix this family glitch. So let's say I, as an employee, I still have affordable coverage, so I'm not eligible for a subsidy, but the tiers, the family tier is not affordable for my family, so they're now eligible. Well, if they are now eligible to be for an exchange for our exchange plan of the premium tax credit, you can now drop them from your plan and make the corresponding change. So that's where the 125 plan would need to be updated to allow that. Also, as probably most people know, in 2020, I think it was the CARES Act allowed, if you go way back to the Affordable Care Act, over-the-counter medicine drugs could be reimbursed by an FSA. I still remember, my father buying loads and loads of ibuprofen and whatnot at the end of the year so that he didn't forfeit his FSA balance. That was out. That was discontinued on the ACA, but that's back. So again, you technically you can't hoard medicines and drugs. You got to buy them, whatnot, for what need to be. But again, OTC medicine drugs can be covered under an FSA, and also menstrual care products. But you may need to amend your 125 plan if you haven't to cover these items. Now, if your plan covers all 213D expenses, right, under the Internal Revenue Code and doesn't specifically exclude OTC medicine and drugs, then there's probably not a plan amendment necessary. Right. But menstrual care products falls under a different section of the code, right, Brett?
Yes.
And so if you want to cover these, we actually need to add these in because these still are not 213D, which is a deductible medical expense. So, if you are covering these, they may need to be specifically called out in that plan. All right. So what's on the horizon? I wish we could be in person so that we could see a hand raise here about who has prescription drug copay accumulator programs, because they're popular. And frankly, I did my whole employment law seminar presentation on different avenues to reduce or minimize prescription drug expenses. And if you were there, thank you. If not, I think you can still sign up to get the webinar versions, which will be coming out soon. So please do that. But keep in mind that these things are, we got to keep track of whether these things are going to continue to be affordable. There's a Johnson & Johnson lawsuit against Save-On SP that's attacking that program, which is probably, I think, the originator of these, most popular. There's nothing significant to report on that. I mean, Brett, you're monitoring this like me, and it seems to be letters to the court about, different things that are going to be disclosed and, different attorneys that are dropping or adding to the case.
Right. They seem to still be battling over discovery requests at the moment.
There's another a lawsuit of ABV, I think is how they pronounce that, versus Payer Matrix. That is in the infant stage too, so nothing necessary to report on there, but we're monitoring that. And actually, Brett, I'm going to remind you on air here. Can we add a tracker to that? Because I don't think we have one on that one.
Okay.
And then we had a recent district court decision in the District Court of DC that basically changed the HHS rule. It said, hey, if you've got one of these programs, it's up to you as the plan to decide whether or not you include the manufacturer assistance towards the out-of-pocket maximum for drugs. You can either do it or you can't do it. And a lot of that came out because there was some discrepancy about how you do this with high deductible health plans. Well, the DC has upended that and said, basically, you got to go back to your old rule. It says you can only exclude those manufacturer assistance dollars for brand name drugs that have a generic equivalent available. The big question is what the case actually did, though, is it remanded the rule back to HHS. And so you're thinking, well, what in the meantime, right? Like, well, HHS examines this. And do you remember the footnote on the decision, Brett?
I don't.
Oh, okay. Brett, I'm ashamed of you. There was a footnote on the decision that said, if HHS is confused about what rule applies during the remand, it should ask the court for its direction, which I assume that they will do, but it hasn't happened yet. So again, I wouldn't, jump and start making all kinds of changes to your copay assistance programs. If you have them, I'd wait to see what happens. And if you work with a provider like Save-On, what Save-On does is they actually take all the drugs that are eligible for their plan, and I think they base it off the Utah state benchmark plan. All of those drugs are non-essential health benefits, and if they're non-essential, then they're not subject to the out-of-pocket maximum under the ACA. Correct, Brett?
That's right.
Mental health parity. I'm not going to jump way into this because I did a full webinar on this last month. But keep in mind, this remains a huge priority of the DOL and HHS. And there have been proposed regulations. I expect final will probably be issued sometime in 2024. Big question, have you gotten your NQTL analysis? If you're fully insured again, I think you can, rest easy that the enforcement is going to be against your insurer, not you. But if you're self-funded, have you asked for this? Have you gotten it? Because if you get a request from the DOL, you have 10 days to turn this over. And I know that this has become an increasingly source of huge frustration, is that employers can't get this with self-funded plans. But I think it's coming around that even though they're probably not adequate in the DOL's eyes, TPAs are starting to provide this. Lastly, in mental health parity, I won't get into the details on whether you can exclude ABA therapy. I think if you really go down the road, you can probably do it, but it's going to be problematic. So if you're excluding ABA therapy, time to think about that change. And it's basically, if you are excluding that, it's putting a target on your back, right, Brett?
Right.
Otherwise, I think we got another slide for this, but there was also a recent Texas court decision that's basically said any of the preventive services that were issued by the United States Preventive Services Task Force, which is the USPSTF, after March 23 of 2010, which is the date that
the ACA was passed.
exactly. Those are a violation of the Administrative Procedures Act because they weren't done by a proper appropriation of Congress. There's a whole law school class on the APA. I don't recommend taking it if you're thinking about going to law school. Anyway, those are arguably not required preventive services anymore. That holding has been stayed, and they are continue to enforce it. So don't make any changes. And frankly, a lot of these task force preventative services are low dollar amounts that I don't think I haven't talked to a client that would want them to remove it at all. It's not the contraceptive coverage requirement that sparks, controversy. So anyway, but keep that in the forefront, and we'll be continuing to monitor that. Otherwise, plan design changes this is my least favorite slide of the presentation. Are you going to institute travel benefits for abortion coverage for those your employees that live in states that are going to outlaw abortion? You got to think about that. Tax consequences, ERISA consequences, state law consequences if they're going to travel, especially if you're operating in states like Texas and Oklahoma that have basically outlawed and made it criminal to aid and abet, which includes paying for abortions. There's also issues of medication abortions, which my understanding is those are the most prominent. These drugs have been litigated whether they can be prescribed at all. So keep abreast of these changes. Coverage for same-sex spouses. If you don't cover that, there's no explicit requirement under a federal law that requires you to. So if you have a self-funded plan, you arguably can exclude those. If you're a fully insured plan, if there's a state law like in Michigan, you can't do that. But if you're a self-funded plan and you don't, I think you need to consider that in light of the Bostock case that basically says you can't, discrimination based on sexual orientation and sexual identity is discrimination. And so if I'm offering coverage to opposite sex spouses, is it discriminatory to not offer that coverage to same sex spouses? Coverage of transgender benefits. Again, we've gone through this whole litany of changes with respect to Section 1557 of the Affordable Care Act, where we had to cover it, then we didn't have to cover it, and then we had to cover it, then we didn't have to cover it. 1557 aside, again, the Bostock case makes that questionable whether you can exclude those. Also seems to be an issue on the DOL's radar. Can you comment on the differences between self-funded and fully insured with CAA, Consolidated Appropriations Compliance? Kind of a broad question there, but I guess the way that I phrase it is the CAA compliance applies to the group health plan and to the insurers of fully insured health plans. So the regulatory agencies have dual in jurisdiction over the insurer of the plan through HHS or the state and the plan. So if you have a fully insured plan that's non-compliant with the CAA, they're most likely going to go after the insurer. With self-funded, it's on the plan. Now the reality is you need to, most of the CAA compliance is admin stuff. So you need to rely on your TPA to administer, but to the extent that they foot fault, if you don't have an indemnification clause, the penalties are going to be on you. Next question, if the SPD is included in open enrollment information, does this cover the communication requirements? I guess the answer to that, Brett, is does the SPD contain all of the required notices? Does it have the Medicare credible coverage notice? Does it have the SPC? Does it have the Women's Health and Cancer Rights Act notice? If it's all in there, yes, then arguably it will cover those requirements, but a review would be highly recommended of the SPD. All right, I think that's it. Thanks everyone for joining us, and look forward to us in November. And again, we hope to do in December a group-wide presentation. And again, there'll be no material prepared, and we'll likely solicit questions in advance as well. Thanks everyone.